Hello, my name is Dr. Rowland Illing, and I'm the Director and Chief Medical Officer of AWS Public Sector Health International. And today I'd like to talk to you about global trends in digital health applied to radiology, with a particular interest in artificial intelligence and machine learning. My declaration of interest is that I'm an employee of AWS. What I'd like to talk to you today about is some of the industry challenges that we're facing across healthcare, some global trends in healthcare spending, 4 particular trends that we're seeing, and I'll give you 3 takeaway points. So first, to those industry challenges. We know that healthcare is facing a large burden at the moment. So we're facing an elderly population, which is getting older. Over a third of the population in Europe is estimated to be over the age of 60 by 2050. We know that there is an ever-increasing workforce gap. There are not enough healthcare providers to provide services to our patients. And again, the WHO estimate that by 2030, there will be a workforce gap of around 14.5 million positions. The amount of digital information is increasing exponentially, as we all know in our day-to-day lives. And on top of this, there is a drive to improve efficiency, with an estimate of around 20% of efficiency that we think could be gained within the current healthcare systems. And that's a conservative estimate. Finally, sophisticated security breaches are happening all the time, with an estimate of over 93% of healthcare organizations experiencing some kind of breach over the last 5 years. And of course, this is all before the last period of time when we've faced COVID. Since the pandemic, we've seen an increasing number of acutely ill patients that's already straining an already strained workforce. Keeping the workforce safe has been a priority, and the requirement to build new services quickly and at scale has been paramount. Here I'm thinking particularly around telehealth. While that's been going on, the health systems have had a need to maintain governance and also face those cost pressures which have been already present. Now, where do we see healthcare systems spending their money? Because that's often a place that we look to look for trends as well. So we see internationally healthcare systems spending their money around certain health system subcategories. So here we see those categories which are marked by size along the bottom, and on the up axis is the year-on-year growth of those subcategories. And we can see that the biggest areas of healthcare spend globally are in the areas of the electronic medical records and global genomics, followed very soon by supply chain, imaging, telehealth, and population health. We see the fastest growing area in clinical analytics and also artificial intelligence and machine learning. So these are areas of rapid growth that we will see come to take precedence in the years to come. So now to my 4 trends. And I'll go through these in greater detail in the forthcoming slides. But first, I would like to give you the takeaway points that I'll actually give you at the end. So this is a spoiler alert, but I'll tell you the answer up front. And my takeaway points to these trends are that industry challenges that I mentioned earlier are already being met by AI. Cloud technology will be the real enabler for scalability and democratization. And I'd like you to think about, while we're going through some of these examples, some examples that you can bring from your own institutions that could potentially be answered by some of the solutions some of our customers have already found to answer some really challenging problems. So to my first trend, which is diagnostics and prediction. This is an area of great focus in radiology in particular. And we've seen during COVID, plenty of examples of artificial intelligence being stood up to answer the questions about both diagnostics and prediction. And I think we can all agree that AI is already having a profound impact on supporting radiologists to provide accurate diagnostics. A great example comes from a recent paper in the journal Radiology, where I'm delighted to see the experience of Brazil reflected by the contribution of Dr. Cesar Nomura from Hospital Sierra Libanese in Sao Paulo. To assist hospitals without chest radiologists and to help provide faster diagnoses, the Hospital das Clínicas Innovation Center, in partnership with the private sector and the federal government, created the RADVID-19 project. Using this AI platform, any hospital in Brazil could send its chest CT to a server where two AI algorithms would analyze those images and return a report with a COVID-19 probability analysis and the extent of the affected lung parenchyma. This facility operates 24 hours a day at no cost to the end user, and reports are delivered back to the end hospital within 10 minutes. A personal experience of introducing artificial intelligence into the largest independent imaging network in Europe comes from the use of AI from a company called Icometrics that I worked very closely with in my previous role. This AI algorithm objectively assesses white matter lesion dissemination in patients with multiple sclerosis. So these small areas of scars in the brain, and it reduces the heavy lifting by analyzing the whole brain volume, not only for the brain volume itself, but also for the amount of scarring of those individual white matter lesions. It takes these whole brain volumes and analyze it against an age-matched and sex-matched normative reference population. So you can see where your patient lies against a normal range. This is really helpful to clinicians and pharmaceutical companies by providing objective measurements to help to decide when to start or when to change treatment and the efficacy of any experimental therapy the patient may be on. In both of these cases, the cloud enables disparate radiology centers to tap into validated AI technology at the point of need, providing the availability and scalability required to deliver that service. So bringing AI to the point of care is key to unlocking the benefit. It doesn't rely on end users in district hospitals to have massive computing power or availability of the data required to derive the algorithms themselves. So on to my next trend, which is around operations and personalization. And when I talk about personalization here, I mean a personalized patient journey and the individual things that can be tailored to a patient, not necessarily the clinical aspects, but the operational aspects around that journey. There's a huge opportunity to optimize operations and removing that unnecessary cost from the system. So failure to attend hospital, first of all, consumes enormous resources. And these are estimated to be over £1 billion per year in the UK through lost appointments. And it's a global issue, with non-attendance estimated to be 43% in the African continent and 28% in Latin America. And these rates have remained unchanged over the last 10 years. The problem is that blanket interventions are wasteful. If you try and call every patient that's due to attend an outpatient appointment or a clinic, it's incredibly wasteful because we don't know who to target. And the complexity of the reasons for non-attendance are very difficult to model. The article here on the top of the slide comes from UCL, and to quote one of the authors, the complexity of the mathematical model its ability to absorb nonlinear associations and complex interactions between many variables is limited only by the availability of data and the scale of the computational resource applied to it. That means that the more compute power that we can provide to some of these questions, the better the chance of us being able to answer it. So the authors of this first paper reviewed missed appointments of patients who are attending MRI. And they looked at a single institution. They looked at 22,000 MRI appointments at a single institution over 2 years. And they took the data about those patients from the radiology information system. So not the whole electronic medical record. This is just the information that's available in the radiology department system itself. Now, normal logistic regression of this data provided an area under the receiver operator curve, that is the likelihood of a correct estimate of 0.07, where 0.5 is 50-50, that's tossing a coin, and 1 is a perfect agreement of the model and the outcomes. So the closer that one gets to 1 for the receiver operator curve, the more accurate the algorithm. So using logistic regression, this is the best, up until now, the best kind of tool for this kind of problem. The receiver operator curve is around 0.7. This group, using gradient boosting machines, using 81 features extracted from the data set, using a tremendous amount of compute power, managed to find a receiver operator curve of 0.85, a significant improvement in understanding which patients are likely not to attend their MRI study. Now, they didn't look to see which was the most predictive feature, but they did look at a composite influence of all of those features. Demographics were not included. And apologies, by the way, if you hear my dog barking in the background. They did financial calculations based on the cost of calling likely non-attenders. So it doesn't have to be perfect, but by identifying those people who are likely not to attend, they thought, okay, how much would a cost to those individuals be? And let's say only 30% of those calls actually result in the patient then coming. How long would it take to break even using that single institution? They modeled that it would take 83 working days in a year for this system to repay itself from being built. Now, if we scale that up against 800,000 scans per year that take place in the UK, that payment back on the cost of implementation comes down to a few days. Prediction of non-attendance at the time of booking opens up really interesting opportunities for preemptive intervention. How can we send transport to patients who are likely not to attend in order to get them definitely to arrive? Can we link to taxi firms and send taxis out? Can we track them by geolocalization? There are a whole host of additional steps that then can be done. My interest is also in real world evidence. So the second paper comes from a paper that myself and the group published earlier this year, looking at the reproducibility of experimental data in the real world. And so what we looked for was the reproducibility of an AI algorithm that takes low dose PET CT scans. So the PET tracer, so the radioactive tracer that's introduced into a patient to look for cancer. If we reduce the amount of radioactive isotope that gets introduced, and an AI processes the image to make it look like a full dose image, does that make clinically relevant scans? What we were able to show was that by reducing the dose by 30%, using the subtle medical AI algorithm, we were able to reproduce full dose clinical scans without losing clinical information. So we had two groups of radiologists, they were blinded to the outcome, and we found that using the AI algorithm was non-inferior to standard best practice. And this is important for two reasons. One reason is that it reduces the dose of radioactivity given to the patient. And for patients with cancer undergoing multiple scans, that's a really important factor. The second, of course, is that by reducing the dose of radioactive tracer, there is a cost reduction as well. So we were able to publish from this a real-world cost-benefit analysis of what the business case for introducing this AI algorithm would be. The third trend I'd like to talk about is mobile health. And this is another fascinating trend as with the increasing use of mobile technology. And again, the vast amount of data that this mobile technology will end up bringing into the system. And the more medical grade mobile technology that we get, the imperative is even greater in order to have the right amount of computing power and storage to analyze it and extract meaningful insights. This example comes from the pandemic, from a company called Humor, who provided Internet of Things devices to people's homes, along with a platform for data collection on the cloud. Doctors are able to track patients' vital signs from a centralized dashboard and identify those who are deteriorating if they have signs and symptoms of COVID, and provide them with advice or admit them to hospital. This paper that was published shows a cohort of 1,700 patients who were admitted to hospital with symptoms that would normally require then further admission and a stay in the hospital. However, they were in that grey area. So these patients were fit enough to be discharged, but only with close monitoring. They found that with close monitoring, 94% who were fit enough for the study, but would otherwise have been admitted to hospital, were able to be managed from home, with the escalation criteria built in to manage deterioration. Of those 6% who did deteriorate and were then admitted to hospital, there was no excess mortality and morbidity compared to all of those patients that previously would be admitted at that stage of the disease. This is clearly able to relieve a great deal of burden from the hospital system and free up much needed hospital beds. The final trend I'd like to talk to is democratization of access to data and tools. So the real game changer over the next 5 years will be this prevalence of machine learning taking place in the cloud. And as I said from the first example, the amount of compute power that's required in end institutions to bring AI closer to the patients is vast, and most institutions are unable to access it on premises. But by moving AI into the cloud, it brings that computing power much closer to the end user. Most organizations have realized the only way it'll be possible to interrogate this vast amount of healthcare data being generated is by storing it securely in the cloud and allowing access to it by authenticated individuals. Data stays under the control of the owner, but secure access is granted. Data sharing is synonymous with data movement. So I'm going to send my data somewhere. Using trusted research environments in the cloud, that's no longer the case. Data does not need to move anywhere. It can stay within the secure confines of the host organization, who can allow access to it by trusted researchers and individuals. And this is a model already used by Genomics England in the UK. And with their partners LifeBit during COVID, they created a federated data set of 100,000 genomes in the cloud. And they were able to provide a cohort of 20,000 patients who'd had severe COVID and a further 15,000 patients who'd had less severe COVID. And comparing that to the 100,000 genome cohort, surface that information to research organizations and pharmaceutical companies who were able to look for genomic predisposition for severity of disease. And this was able to be reviewed anywhere in the world, assuming the correct authentication and access to that data. It's a hugely powerful model. A similar example from radiology comes from Radboud University in the Netherlands. Professor Bram van Ginneken's group wanted to build an integrated global infrastructure to develop machine learning solutions. They developed an online platform for end-to-end development of machine learning in biomedical imaging, loading into a simple-to-use browser with a latency of less than 10 milliseconds from wherever the researcher was in the world. So they were able to surface data and also all of the machine learning tools next to the data. So researchers, without access to either, but a great idea, are able to go and interrogate it and develop new AI and machine learning. Over 45,000 researchers have signed up to this platform where all the data and tools are available for their use. Simplifying and demystifying some of these tools will allow much broader access by groups of researchers to machine learning in general. Whether they're very deep machine learning experts, they can access the raw data and the raw tools at the bottom of the stack. There are a whole series of run-through machine learning platforms in AWS, such as SageMaker Studio, where there's a managed service for AI pipelines. And so whatever level of machine learning expertise, from those deep machine learning experts to data scientists and clinicians, all have an opportunity to tap into this power. And I think we can all agree that there are enough questions out there, and that the more people we have working on them, the better. It will allow exponential discovery if more people can access and ask those questions, which is hugely exciting. But of course, it does raise more questions about how to sort through all of that data and all of those solutions to choose the best. So I'll go back to my takeaway points. And looking at those industry challenges I mentioned at the beginning, I hope that I've surfaced that some of these challenges are already being met by artificial intelligence and machine learning. Also, that cloud technology will enable scalability and democratization of access to these tools and also to finished algorithms in the field. And so to my final takeaway point is, what problems do you see in your clinical practice that you think you can address using some of these tools? Thank you very much for your attention. I hope you found it interesting, and I look forward to you taking this away and developing your own AI and machine learning practices. Thank you.
Perfecto. Agradecemos al doctor Rowland que aceptó participar de esta charla y de la jornada. Y también agradecemos a Candelaria Milano, con quien nos puso en contacto con Rowland. No sé, Candelaria, si querés comentarnos algo, te permití hablar, si querés desmuteate.
Dale, bueno, muchas gracias a todos por haberse sumado a esta charla, y lo que les quería comentar era que cualquier pregunta adicional o tema que quieran profundizar de lo que presentó el doctor Ealing, pueden acercarse a nuestro stand, escribirnos el mensaje y les vamos a canalizar la consulta y enviarles la información que requieran.
Perfecto. Muchísimas gracias, Candelaria, muchísimas gracias por su predisposición. Les podés pasar nuestro agradecimiento al doctor Rowland.